Okay, so I'm going to talk about lung manifestations of rheumatological diseases. And yet I have just moved, this is obviously a picture of Toronto, or maybe not so obvious. I've just moved to UBC in Vancouver, so if I seem a bit disoriented, it's because I've moved during a pandemic, which has been a challenge. Okay, now my slides are not advancing. Why is that? Why are my slides not advancing? There we go. Okay, they're just slow. Okay, I have no conflicts of interest. So over the next hour, I'm going to spend the first half hour talking about pulmonary vasculitis. We'll talk about the clinical presentations of pulmonary vasculitis, and hopefully by the end of this, you will have a little better understanding of the treatment and the rationale for treatment that's available for pulmonary vasculitis. And then after that, I'm going to talk about pulmonary presentations that are associated with connective tissue disease and inherited autoinflammatory disease. And the ones that come to us are mainly the progressive fibrosing interstitial lung diseases that are associated with rheumatological conditions. And so I'll be focusing on those. Okay, so why is this important? Okay, so I always tell our fellows that you need to know something about rheumatology and the rheumatological manifestations of pulmonary disease, because you would be surprised how many times you are the first specialist consulted to the emergency department when a child presents with a rheumatological condition. Because if they have a pulmonary component of their rheumatological condition, obviously sometimes it is the predominant important clinical picture, and so you may be the first subspecialist who sees the child in the emergency department, and you need to recognize when it is a rheumatological condition and when you need to get the rheumatologist to see the child as well. Of course, we're often also consulted by rheumatologists. And lung disease can be very important in the rheumatological conditions because it can be severe, rapidly progressive, and fatal in some conditions. And for some of these conditions, we are actually the primary driver of the therapy. And this is predominantly in the vasculitic conditions where children have isolated pulmonary involvement, like isolated pulmonary capillaritis. So that's similar to the isolated CNS vasculitis, where the neurologists are primarily the driver of the therapy there rather than the rheumatologists. So what kind of diseases do we most often encounter in pediatric pulmonology? Well, we have the rare rheumatological conditions that have serious pulmonary involvement that is common. So this is mainly the vasculitides, like EGPA in particular. That's the most common vasculitis that we see, and scleroderma. So these are obviously rare rheumatological diseases, but pulmonary manifestations are very common. And then we have the common rheumatological conditions like JIA and lupus, where pulmonary involvement is rare. But because the diseases are common, obviously we are going to sometimes see pulmonary complications of these diseases. So moving on now to vasculitis. So what is vasculitis? I think you probably all learned about this in medical school: inflammation of the blood vessels. And pulmonary vasculitis is one of the rarer manifestations of vasculitis. It's usually a manifestation of some underlying recognized systemic inflammatory disease, or it may be isolated pulmonary vasculitis, as I already mentioned. And this is very important to have a good understanding of pulmonary vasculitis because it's always potentially fatal. When you have bleeding in the lungs, obviously, that can kill a child. Now, pulmonary involvement can happen in any of the systemic vasculitides, but Generally, it happens mainly with small vessel vasculitis. You'll remember from medical school that vasculitis is categorized by these Chapel Hill criteria that divide it into large vessel vasculitis, medium vessel vasculitis, and small vessel vasculitis. And it is the small vessel vasculitides, and particularly the ANCA-associated vasculitides that are associated with pulmonary vasculitis. The clinical presentations of pulmonary vasculitis, there's predominantly three, and I would like you to, by the end of this session, I hope these three are sort of nailed into your, imprinted into your brain, so that when you see children in emergency with these clinical presentations, you'll think about vasculitis. Diffuse alveolar hemorrhage, pulmonary nodules or cavities, and tracheobronchial stenosis. These are the three primary modes of presentation. So diffuse alveolar hemorrhage, these kids present with diffuse infiltrates, often with a peripheral type of distribution, but certainly an alveolar pattern, and anemia. And they may or may not have hemoptysis. Actually, most of the time they do not have hemoptysis. Remember that when you have alveolar hemorrhage from a small vessel disease, you're having bleeding at the capillary level. And the capillary level of the pulmonary system is a low, very low pressure system. And typically the bleeding is happening at a slow rate. And so remember that your alveolar surface area in an adult is the size of a tennis court. Remember that from medical school? So you can have an awful lot of blood filling the alveolar spaces and have a very low hemoglobin and not have any hemoptysis. So it's quite different than the type of hemoptysis you see in, or the type of bleeding you see in cystic fibrosis, where you have bronchial artery bleeding at a systemic level and you get hemoptysis. Sometimes these kids have large volume hemorrhage all of a sudden, and if they do, then they'll present with hypoxia and respiratory failure. Sometimes you'll find them in the ICU. You'll be consulted for a clinical picture of ARDS, and that clinical picture may be actually due to diffuse alveolar hemorrhage. And sometimes you'll see these kids having a very chronic, insidious onset with cough, dyspnea, and they may or may not have fever. But they may not be overwhelmingly sick when you first meet them. The second presentation is with pulmonary nodules or cavities. So on the left side here, you see a big granulomatous lesion in a kid with GPA. So this is a very common presentation in GPA. On the left, the CT scan shows actually a cavitating nodule. Often the radiologists will call this a pulmonary Cheerio, and you can imagine why they do. But again, these are classic presentations for GPA vasculitis. And then the third presentation is with tracheobronchial stenosis. And this is quite specific for GPA as well. On the left window here, we see a CT scan from a child who has a pinhole bronchus in the left main stem bronchus, okay? This child actually eventually lost her left lung because this bronchus, this was before we recognized tracheobronchial stenosis as a problem in kids with GPA, and this stenosis progressed to complete obstruction and she actually lost her left lung. And on the right side, you see a tracheal stenosis in a teenage boy, again, who turned out to have GPA. But I can tell you that this boy presented to our emergency department, and our pulmonary fellow was the first person to get consulted on, and I happened to be the faculty on staff, you know, and I was with him when he got the call from Emerge, and it was a boy who, you know, was kind of hoarse and had been having some dyspnea, And I was overhearing the story, and I said, the kid's probably got vocal cord dysfunction. Then, of course, when we got down to the emergency room and saw the kid, you know, when we got into the history, he had the complete history that fit with GPA, including issues with recurrent sinusitis and nosebleeds, and he'd had 20 pounds of weight loss, right? So it's very important that we recognize these other associations that would go with GPA. So GPA, I think it's quite important for you to know about because this is the most common pediatric vasculitis. Even though it is rare, it's still the most common. And these kids present usually quite sick with constitutional symptoms like fever, weight loss. Upper airway involvement is almost universal, not quite, but almost. Particularly with epistaxis and sinusitis. Nasal septal perforation is sort of a late sign. And the saddle nose deformity, which you'll see in textbooks, again, this is a very late finding. I would hope that you don't see this in a fresh presentation in the emergency department. Renal failure is another one of the life-threatening ways that they present in the emergency department. And then lower airway involvement, again, is very common in GPA. It happens in about 80% of cases with either pulmonary nodules or tracheobronchial stenosis or diffuse alveolar hemorrhage or a combination of the above. And so you can understand why often you get consulted to the emergency department before the rheumatologist does. Microscopic polyangiitis is the second most common small vessel vasculitis that we see, but it is quite rare in children. It's much more rare than GPA. And this vasculitis typically presents with profound constitutional symptoms as well as joint involvement and renal involvement. Lower airway involvement happens in only about half of the kids, and classically that's with diffuse alveolar hemorrhage. It's interesting, the pattern of presentation here, because the most common mode of presentation of MPA in children is with isolated renal disease. In adults, it's often a combination of pulmonary and renal disease. But we also see children who present with certainly they have the diffuse alveolar hemorrhage and the autoimmune profile of microscopic polyangiitis, but no renal involvement. EGPA is the last of the small vessel vasculitides. This used to be called Churg-Strauss disease. This is actually exceedingly rare in children. But it is important for you to know about it because it is another one of these life-threatening vasculitides that sometimes sneaks up with a very sort of progressive worsening symptoms. And often they have this usually they have this prodromal phase of worsening asthma symptoms. They've had chronic rhinosinusitis and nasal polyposis. They also often have constitutional symptoms with weight loss. And if you do blood work, they have eosinophilia. I think one of the most important things to recognize is that these kids often have cardiac disease that doesn't get recognized. And it's quite important to screen children with EGPA for cardiac disease because children actually die of cardiac disease or CNS disease with EGPA. The last kid that we had present with EGPA was in hospital for 3 weeks before it was recognized that she had had a myocardial infarction, a life-threatening myocardial infarction. So that's important to remember. Lower airway involvement is very common in EGPA, and typically it is they have patchy migrating pulmonary infiltrates. Very rarely do they have diffuse alveolar hemorrhage. And finally, isolated pulmonary capillaritis. So I've included this. I mean, I know traditionally, often pulmonologists don't include this with vasculitides, but I do because it is a vasculitity. And I think it's, if you think of it as a vasculitity, then the therapy that we use for isolated pulmonary capillaritis makes a lot of sense. And this is rare, but it is more common than EGPA. For all of you, those of you who work in larger centers, you're probably going to see at least one of these during your pulmonary fellowship. These kids present with isolated diffuse alveolar hemorrhage. They may or may not be ANCA positive. If they are ANCA positive, it's usually an MPO antibody, like you see with microscopic polyangiitis. And these kids follow a very similar course to the other vasculitides that we just talked about, in that they have very frequent relapses, and if you don't treat them, they have a very high mortality rate. If you look at the old literature from the 80s, this disease had a mortality rate of close to 90% in the first year, before people realized that it responded to prednisone therapy. So that's one of the reasons that it's good to think about it in the same basket as vasculitides. And this is a disease where extrapulmonary manifestations may also develop over time. I'm not sure what just happened, but I've lost my PowerPoint presentation. Can you still see it?
Yeah, we can see the EGPA slide.
Okay, what has happened? There we go. Screen sharing has stopped. But you can still see it.
Not anymore, no.
Oh, okay. Let's see. I wonder if it was because I didn't actually touch my computer. Okay, sorry guys. I am not very good at this, obviously. Now can you see it?
Yes.
Okay, okay. We'll go back to the isolated pulmonary capillaritis. Okay, we'll go back into PowerPoint presentation mode. There we go. Okay. So the literature would suggest that with isolated pulmonary capillaritis, about 25% of the children will develop other types of vasculitis, predominantly renal disease. And certainly that's been my experience. I've had children with IPC who've developed renal vasculitis and children who've developed CNS vasculitis. So the revised Chapel Hill consensus criteria would actually classify isolated pulmonary capillaritis as a single organ vasculitis, the same way that it now categorizes CNS, isolated CNS vasculitis. I think one important thing to recognize here is that it's very easy to misclassify pulmonary capillaritis as idiopathic pulmonary hemosiderosis if your ANCA test is negative and if you have bland pulmonary hemorrhage. So what do I mean about that? We'll come back to that, okay? For now, I want you actually to do this poll. Which of the following vasculitides is least likely to have a positive ANCA serology? EGPA, GPA, IPC, or MPA? Will I be able to see the poll?
Okay, I just
yes,
launched the poll. Are you able to see it?
Yep,
okay.
I am able to see it. Wow. Okay. I see it. Okay. I'm not sure how many people are on the, let's see, 44. 26 of 44. Okay. Have we given enough time? Yeah, I think so. Okay. So most of you said IPC, and some of you said EGPA, and a few people said microscopic polyangiitis. Okay. So how do I get rid of the poll? Do I just close it? No,
yeah, go ahead and just close it.
Close it. Okay. There we go. Okay. So the correct answer is IPC, although although actually, although it's a bit of a, you could argue that it could be EGPA, okay? So let me see, will my slides advance? No, my slides won't advance. There we go. Okay, so ANCA is very central. The ANCA autoantibodies are central in the pathogenesis of ANCA-associated vasculitides. They result in both direct and indirect endothelial cell injury. And then there are other molecular events that cause granuloma formation in GPA, and the eosinophilic infiltration of the tissues with EGPA. But certainly most of us feel that the ANCA autoantibodies are very central to the pathogenesis of the small vessel vasculitides. So how many have positive ANCAs? Okay, so in GPA, actually most are ANCA positive, almost 100%, probably not quite, and those that are not may have other autoantibodies, endothelial autoantibodies, that you can demonstrate in research labs. The GPAs tend to be anti-PR3 or C-ANCA positive. Microscopic polyangiitis, about 70% are ANCA positive, and they tend to be P-ANCA or anti-MPO positive. EGPA, okay, so for those of you that guessed that EGPA may have the lowest rate of ANCA positivity, I wouldn't blame you for answering that. And actually, if this was an exam question, maybe I would give you a point for saying EGPA. Because if you look at different publications, the rate of ANCA positivity in children is anywhere from 0 to 40%. And adults, it's 40 to 50%, okay? And interestingly, there has just been some data published from adult cases of EGPA with isolated lung disease that shows that the serology is anti-MPO negative, that they often have anti-MPO antibodies in their BAL fluid, which suggests that they may actually be making their autoantibodies in the lymphoid tissue, the bronchial lymphoid tissue, which is a really interesting phenomena. With IPC, again, we actually don't have any published data on ANCA positivity. In my clinic, it's about 40 to 50%. And so if you guessed either IGPA or IPC, I'd probably give you points. So the initial work of pulmonary vasculitis, of course, includes CBC and coagulation profile, looking at it, doing an inflammatory biomarker workup. Renal workup is very important, and autoantibody panel. A high-resolution CT of the chest is very helpful for looking for lung disease. You should consider CT sinuses if there's a clinical suspicion of sinus disease, or if you think the diagnosis is GPA. And you should do an echocardiogram to rule out myocardial disease and pulmonary hypertension. And if you are concerned that there's diffuse alveolar hemorrhage, again, remember, there's usually not hemoptysis, so you would need to do a bronchoscopy to demonstrate that you have blood in the alveolar spaces. And the bronchoscopy is also quite helpful for identifying large airway lesions. It's also helpful to rule out infection. And if all of your investigations haven't yielded the diagnosis, then the last thing to think about is a tissue biopsy. And the last tissue we always think about biopsying is the lung, because it has the most morbidity associated with it. But certainly with isolated pulmonary capillaritis, if the child is ANCA negative, we usually end up having to do a lung biopsy. The bronchoscopy in diffuse alveolar hemorrhage is quite important. On the left panel here, I'm showing some airways that obviously have fresh blood in them, but you usually don't see that with diffuse alveolar hemorrhage. You actually usually see very clean looking airways. And then when you do your BAL, you get this progressively bloody return. And when you send it to the pathology lab to look under the microscope, they see hemosiderin-laden macrophages, and then you have your diagnosis of diffuse alveolar hemorrhage. You'll probably hear more about that next week in your ILD session. Bronchoscopy is quite helpful for also showing airway stenosis. So on the left panel, you see a pinhole, left main stem bronchus, and in the right panel, you see right main stem bronchus, stenosis, and also ulceration that is quite common in the vasculitides. This is a kitty who has EGPA, and with EGPA, they often have these really interesting airway lesions that have been quite well described in adults with EGPA, but not really described in children. But it is the same disease in children and adults, and so has similar manifestations in the lungs. So you see these. You often see these plaques, and if you actually are able to get your biopsy forceps on them, it could be quite helpful because you will see eosinophilic granulomas. So if you do end up doing a lung biopsy, an open lung biopsy is the gold standard for diagnosis, but it can be quite difficult to interpret because sometimes in children that have life-threatening diffuse alveolar hemorrhage, we've given them steroids, high-dose steroids to save their lives, really, before we've thought about doing a lung biopsy, and that will, decrease your, that may actually obscure your ability to make a diagnosis. The other thing is that vasculitis is always a patchy disease, whether it's in the lungs or the kidneys or the skin. It's typically a patchy disease, and so sometimes we're doing biopsies relatively blind, and you may not actually get the part of the lung that has vasculitis, and then the findings may be very subtle in a capillaritis. So now we're going to come back to my point about idiopathic pulmonary hemosiderosis versus IPC. So classically in pediatric pulmonary, we have divided isolated diffuse alveolar hemorrhage into autoimmune mediated, which is idiopathic pulmonary capillaritis, and then whatever you want to call it, idiopathic pulmonary hemosiderosis. And so IPC is where we see evidence of a capillaritis with a neutrophil infiltrate and fibrinoid necrosis of the capillary walls, or we have a positive ANCA antibody, and then we're happy to call it pulmonary capillaritis. On the other hand, if we do a lung biopsy and we don't see any evidence of that capillaritis, but everything else looks the same, basically. We may or may not see mild fibrosis. It's pauci-immune, which means we don't see immune complex deposition like you would see in lupus or glomerular basement membrane disease. And you may see alveolar epithelial cell type 2 hyperplasia, but with IPH, you just see bland alveolar hemorrhage, okay? And my concern is that the two diseases behave very similarly clinically. They both respond to the same medications that we use for autoimmune inflammatory disease. And you can see if it's a patchy disease, how you could very easily miss areas of capillaritis and just get areas where you see bland pulmonary hemorrhage. And the corollary of that actually is that in lupus, where you do have pulmonary capillaritis, sometimes, rarely, but sometimes, in adult studies, they have shown that if you do biopsies in different patients who've had diffuse alveolar hemorrhage with lupus, sometimes you see pulmonary capillaritis, and sometimes you just see bland pulmonary hemorrhage. So it may be a sampling issue, and it may be that we're talking about the same disease with these two things. But the jury's not out yet on that yet. So you can think about that, and the next young generation, you can figure that out. It is really important to think about IPC as a systemic vasculitis because these diseases are rapidly fatal if they're untreated. GPA mortality is 80 to 90% if you don't treat it. And the other issue is that we really don't, because these diseases are rare in pediatrics, our treatment options are extrapolated from adult randomized controlled trials. But for those of you who've done any rheumatology training, you know that modern treatment of rheumatological conditions and oncology conditions are divided into induction and maintenance phases. And I think it's very helpful to think about even conditions like IPC in that same manner. So for vasculitides, the induction phase is typically the first 6 months of treatment. It used to be with high-dose steroids and cyclophosphamide. Now rituximab has been shown to be just as effective as cyclophosphamide. So certainly in children, our standard of care has changed to using steroid and rituximab for reduction of induction of remission. The next maintenance phase is typically for the next 24 months. And we use either low-dose prednisone with azathioprine or rituximab. And again, studies are showing that rituximab is probably more effective than the combination of low-dose prednisone and azathioprine for treating this. So certainly, all of our children who have demonstrated pulmonary capillaritis, we now treat with a regime like this. If they have IPH and no positive autoantibodies at my center, we can't use rituximab. You know, we have to show that they're going to fail treatment with just steroids, and then we can get rituximab. But my experience is they all end up needing rituximab in the end. Plasmapheresis is a therapy that is reserved for end-stage renal disease, children who present with end-stage renal disease, and diffuse alveolar hemorrhage that's not responding to other immunosuppressive therapy. And that's all I'm going to say about that for now. I think I've already made most of those points, so I'm going to move on and just say a little bit about lupus. You're all familiar with lupus. Lung involvement, just about every pulmonary manifestation that you can think about has been reported in lupus, probably because lupus is the most common rheumatological condition that we see. By far, the most common pulmonary manifestation is pleural effusions, typically at presentation, often at diagnosis, due to a serositis. But you can rarely see diffuse alveolar hemorrhage. That's probably the second most common pulmonary presentation. Okay, now I don't know about your centers, but at my center, we very, very rarely get consulted for pleural effusions with lupus. And the reason is they usually have all kinds of other manifestations that jump out and say, I've got lupus. And it's very common when they present with acute lupus to have these effusions. And the rheumatologists know that when they treat with steroids a few days later, the lungs look like this. The effusions have cleared. They clear very quickly. You know, every once in a while, you will get a kid who has chronic effusions, and that's a whole other thing to think about. That is a problem that you may get consulted for in lupus. And the last point I want to make about lupus and vasculitides is that you always have to think about thrombosis when you're thinking about lupus and vasculitides. If you have a child who's got persistent dyspnea and hypoxia, you have to think about thrombosis. I think probably most of you are aware of the association between antiphospholipid antibodies that you might see in lupus and the risk for thrombosis. But you may not be as aware that there's actually a similar risk with vasculitides. So that was demonstrated a number of years ago in adult ANCA-associated vasculitides, and it's now been demonstrated in cohorts of children with GPA, which is the most common pediatric vasculitide. And one of my fellows actually published a pediatric case report of a child with pulmonary capillaritis who also had thrombosis. It was a very late presentation of pulmonary capillaritis. And I think completely makes sense when you think about small vessels and inflammation, that you're going to have a hypercoagulable state, and that you may be at risk for pulmonary embolus and other forms of thrombosis if other vessels are involved. Okay, so now we're going to move on to the next part of my talk, which is a little bit shorter. We're going to move on to the fibrosing interstitial lung diseases that you're going to see associated with rheumatological conditions. So now we've got our next polling question. Nonspecific interstitial pneumonitis, or NSIP, as we like to call it for short, is most likely to be associated with which of the following diagnoses? EGPA, JIA, sarcoidosis, scleroderma, or surfactant protein B deficiency. Okay, so let's see the winner here. 41% of you said scleroderma, 34% said JIA. So the correct answer is scleroderma. Okay, that's the most common cause. You certainly could see NSIP with JIA, but it's not typical. We'll talk a little bit about JIA, but certainly the most common NSIP is the most common pathology you will see in interstitial lung disease associated with any of the connective tissue diseases, including mixed connective tissue disease and the dermatomyositis. So certainly if you see NSIP in a patient, it should make you do a workup for connective tissue disease. Okay, so the fibrosing ILDs in pediatric rheumatology, in the teenagers, it tends to be most commonly, not exclusively, but 9 out of 10 cases you're going to see, or that's my estimate. That's not a published estimate. It's my estimate from my head. Most cases that you're going to see are going to be associated with scleroderma, rarely with JIA, with juvenile dermatomyositis, mixed connective tissue disease, or overlap syndromes. You will also see it in infants and toddlers, okay? And typically in the infants and toddlers, why am I not advancing? Sometimes my screen doesn't want to catch up. My slides are not advancing. Are they advancing for you?
No, they're not advancing.
I wonder why. There we go. Okay. Yep. So infants and toddlers, you will see, again, this is very rare, but you will see infants and toddlers who present with classic CT that looks like classic interstitial lung disease. When you biopsy, it may have an NSIP pattern or a different type of fibrosing lung disease pattern. And when you see this in infants and toddlers that have other features of systemic rheumatological conditions like a vasculitic skin rash or arthritis, then you have to think about some of the genetic diseases, genetic autoinflammatory diseases that have been described over the last few years, like sting-associated vasculopathy of infancy and COPA mutations. So a little bit about scleroderma. This is a multi-system disease involving the skin, the lung. It can involve all of the different organs. It's very rare in children, but children who develop systemic scleroderma often have pulmonary involvement, and it may be fatal. So it's important for you to know about this. Pulmonary involvement is almost exclusively interstitial lung disease and pulmonary arterial hypertension. They often have GERD and aspiration, so you have to think about whether that's causing lung disease as well. And classically, there's a very insidious onset of symptoms with scleroderma interstitial lung disease. Usually they start with some dyspnea and dry cough. Often you will see CT changes before they have any symptoms, and you will see changes in pulmonary function tests with a restrictive pattern and a decreasing DLCO before they develop any symptoms. And they have this classic pattern of often having honeycombing, like you see here, and traction, bronchiectasis, septal thickening, classic pattern. And again, classically on pathology, you will see an NSIP pattern. In adult scleroderma, sometimes you'll see a UIP pattern, but most often it's an NSIP pattern. Usually you don't need a lung biopsy unless there is a diagnostic dilemma. If you've got a clear-cut case of diagnosed systemic scleroderma and they have a CT scan that looks like scleroderma ILD, you don't need to do a lung biopsy. But it's not always that straightforward, so sometimes a lung biopsy is helpful. And of course, as I mentioned, you always have to think about aspiration and infection, particularly if they're immunocompromised as causes of diffuse lung disease. It's important to recognize lung disease in scleroderma because it does respond to therapy. First-line therapy is MMF and low-dose prednisone. Second-line therapy is typically cyclophosphamide. And we do have a new arsenal of treatments for scleroderma-associated fibrosing lung disease. Nintedanib, which is an antifibrotic medication, which is used for IPF in adults. It has now been shown to basically have exactly the same effect in scleroderma-associated interstitial lung disease as it has in IPF, in preventing the fall in pulmonary function that you see. And so, it's actually now approved for treatment of adult scleroderma lung disease. And I think it's very important for you to know if you are seeing children up to age 18 years with scleroderma associated lung disease or any other fibrotic lung disease associated with a rheumatological condition. There's actually now a trial going on in children from 6 to 18 years of age with this drug, this antifibrotic drug. And we have a lot of hope that it actually may be even more effective in children than it is in adults. And I think you're going to hear more about that study probably from Lisa Young next week. So as you meet these patients, you can think about enrolling them in a trial. I'm going to move on because I don't want to cut time from the next speaker. JIA, I wanted to say a little bit about this because JIA, it's very rare to have lung disease associated with JIA, but in systemic JIA, sometimes they develop severe progressive interstitial lung disease. And again, it's a small fraction of the children with systemic JIA, but it's very important because it is a terrible disease. It seems to march on, not be responsive to therapy, and often can kill a child. And so it's very important to be aware of this. This disease has actually been described for a long, long time. The first case reports of this lung disease associated with SJIA were from like 1996, so it's been around for a long time. But what is alarming is that in the last decade, there have been increasing an increasing number of cases reported, particularly across North America. And this is really concerning rheumatologists. And so they've been able to describe the epidemiology of this much more, and actually able to describe the prognosis of this disease much more. This is a disease where there's a very insidious onset in children with SJIA. They often present initially with clubbing and no symptoms, and then they develop symptoms of dyspnea and cough. And so this is something you have to be aware of in the SJIA population. On high-res CT, they often have patchy but extensive disease with subpleural and interlobular septal thickening, lots of ground glass opacifications, and they may have a picture that looks like PAP with crazy paving. If you do a lung biopsy, they have these features of pulmonary alveolar proteinosis plus an ELP-like picture, so it's really a mixed picture on pathology. And what's important is these children are often under the age of 5. These are young kids, and often they've had a very severe course of SJIA with increased episodes of macrophage activating syndrome, and they've often been treated with more than one biologic therapy. And so there's an ongoing debate about whether the lung disease is related to biologic therapy. But this is with more recently published case series in the past year. I think we've gotten to see a better picture of the prognosis in SJIA. And we've got a slightly different picture from a Cincinnati cohort where there were no deaths, and half of them stabilized over time, versus a sort of a North American case series, which shows a 42% survival at 5 years, which is certainly not great. So I think this is a disease you need to be really aware of and follow very carefully. JDM is another disease that can be associated with fatal interstitial lung disease. You probably have all learned about JDM in your pediatric residency, but you probably have not seen a case of interstitial pneumonitis associated with JDM, because it's very rare. But when it does happen, beware, because it, again, progresses very, unlike actually SJIA with JDM, it tends to progress very rapidly. And it's often fatal. Having said that, this is a case from my own center, which was a child with JDM who actually presented initially with lung disease and no other symptoms of JDM. She presented with cryptogenic organizing pneumonitis on lung biopsy, and we treated her with prednisone, and then when we weaned her off the prednisone, she represented with full-blown JDM. So that gets back to my point about, remembering that often, we may be the first subspecialist to see kids who actually have rheumatological conditions. Just a little bit, I think this is my last slide, on the autoinflammatory diseases. Of course, familial Mediterranean fever is the most common of the autoinflammatory diseases, and it almost universally has involvement of the lungs with pleuritis. But I don't know about your centers. At my center, we never get consulted on those kids, because I think it gets recognized and treated by the rheumatologists, and we rarely have a consult for familial Mediterranean fever. But it certainly is the most common of the autoinflammatory diseases. So you're more likely to see that than SAVI or COPA. But SAVI has this classic picture of infants presenting with interstitial lung disease and vasculitic rash that's often on the hands and feet and the face. And with COPA mutations, they often have a non-erosive arthritis, and they may or may not also have renal disease. And they tend to have a follicular bronchiolitis when they're very young, and then develop into a pulmonary hemorrhage syndrome as they get older. So again, COPA should be in your differential diagnosis if you have a teenager who's got a picture that looks like IPH or diffuse alveolar hemorrhage, and they've also got arthritis or renal disease. Okay, we talked about that already. So I'm going to finish just with some of the pearls to reinforce these points. Remember that pulmonary vasculitis can present as diffuse alveolar hemorrhage, pulmonary nodules, or tracheobronchial stenosis, right? So when you see those things in the emergency department, think that it could be part of a rheumatological disease. Pulmonary vasculitis is usually associated with ANCA-positive vasculitides, except with idiopathic or isolated pulmonary capillaritis. It may or may not be ANCA-positive. Thrombosis is associated with both lupus and vasculitis. If you see NSIP, histopathology in a child with interstitial lung disease, it certainly should prompt a workup for connective tissue disease. Systemic JIA and JDM, these are associated with interstitial lung diseases that can be rapidly fatal. And consider genetic testing for autoinflammatory disease when you see patients with interstitial lung disease that is associated with vasculitic rash, atypical lupus, or JIA, particularly if there is a family history of similar disease or if there's consanguinity. And finally, always talk to your rheumatologist for therapy choices in the induction and maintenance phases. They are going to direct the therapy for most of these cases. They are going to tell you what works and does not work. But for most of you, when you're dealing with isolated pulmonary capillaritis, they're going to leave that to you, just like they leave the isolated CNS vasculitis to the neurologist. But you can still consult the rheumatologist for suggestions on therapy and how to monitor side effects of the therapy and how to best deliver it. And just as I'm finishing, I just want to acknowledge, I mean, a lot of what I have learned about rheumatological conditions and vasculitis comes from working with the pediatric vasculitis team at Toronto Sick Kids Hospital and also working with the North American Child Network. And now I'd be happy to take a question or two if there is time.
Yes, thanks very much, Sharon, for the talk. It was really great, really a ton of information. We have a few questions in the chat. If anybody else has questions, please go ahead and put them in the chat as well, or if it's something that would be easier to ask in person, you can ask to be unmuted. Sharon, I don't know if you can see the chat. The first question comes from Carlos Flores. He says he has a patient identified as IPH who has a negative room workup lung biopsy with no capillaritis. He's not improving with multiple chemo drugs or steroids weaning. He's now on rituximab. His question is, at what point should he start thinking this is misclassified IPS, and what could he do to look for it? Are there further treatment options if rituximab fails? Thanks. So it's IPH versus IPC, and what to do.
Yeah, that's an ongoing controversy, right? So, I mean, even in my own institution, okay, I used to do lung biopsies in all these kids that presented with isolated diffuse alveolar hemorrhage. And what I learned, actually, was as I started to do autoantibodies on testing on all of them, was some of them actually had positive ANCAs, and when we biopsied them, they actually only had bland pulmonary hemorrhage, okay? So, which to me suggests they have a capillaritis, despite not showing capillaritis on the lung biopsy, right? So I tend to think of all of these kids in the same spectrum as an autoimmune disease, okay? The rheumatologists do not think the same way. They think that to treat as a vasculitis, you have to have either ANCA positivity or evidence of capillaritis on your lung biopsy, right? And so for me, because I actually was not able to get rituximab for those kids, I would start with prednisone and Imuran in those kids, and I would have to demonstrate that they failed that therapy, and then I would be able to use rituximab. The same way, actually, that I think the nephrologists have the same issue with their renal vasculitis. If their renal vasculitis is ANCA negative, many of them are not able to get rituximab to treat their renal vasculitis, and they have to show that the disease has progressed and isn't responding to steroids and Imuran or MMF, and then they're able to get rituximab. Does that answer your question?
Looks like yes.
Okay.
All right, thank you. So next question was from, sorry if I, Parisa Kabiani. For autoimmune diseases, do you recommend monitoring disease with CTs, PFTs, or serum markers?
Oh, yes. Okay. It depends exactly on what the disease is. So for pulmonary vasculitis, like if they've had positive autoantibodies to start, yes, I think you need to monitor autoantibodies, every 3 to 6 months, because autoantibodies returning have not excellent, but good predictability for the disease coming back. So it's concerning when you see autoantibody positivity coming back. Should you repeat CT scans? Well, there's 2 reasons to repeat CT scans, okay? With pulmonary capillaritis syndromes, the CT scans are pretty sensitive at showing you if there is bleeding in the lungs. You'll see ground glass opacification. Now you have to make sure that's not infection going on, but it's pretty sensitive for that, and sometimes you may want to do that rather than subjecting a child to a bronch all the time. The other thing is that if there is recurrent pulmonary hemorrhage going on, you will start to get fibrosis, and so the CT scan can be helpful also for monitoring progression of fibrosis in the lungs. So like, how often should you do a CT? So at my center, we do them every 2 years. We actually have a protocol where they're done at baseline, and then we repeat them after the induction phase. So it's 6 months, right? And after that, we do them every 2 years. I think there are no guidelines as to how often you should do them, but you get a lot of information from chest CT scans with a relatively low radiation dose in 2020, and so I think it's quite worthwhile doing them. And what was the third thing? Inflammatory markers, biomarkers?
Yep. Yeah. CT,
yeah.
PFTs.
If you have it, yeah.
Yeah.
Inflammatory biomarkers, so we're talking about things like ESR, CRP, right? Like, again, those should be monitored routinely with your ANCA autoantibodies. So usually we do those every 3 to 6 months. During more active phases of disease, like at the beginning, they would be done a minimum every 3 months. If the disease goes into remission and has been stable for a long time, we may only do them every 6 months.
Okay. Next question is from Bayan Abdallah. Question was, can IPC be misdiagnosed as IPH if the biopsy is done after a short course of steroids? So it's nodding yes.
Yeah. So, I mean, the answer is yes. Whether it's the steroid causing the negativity or like the patchiness of the disease, I don't know. Certainly the neutrophilia that you see in diseases like GPA, when you pulse with steroids, it goes away pretty quickly, right? So I think you could, certainly mask a capillaritis picture, but nobody knows for sure. Certainly, I have had children that I've treated with pulse steroids because they have life-threatening pulmonary hemorrhage, and then we've gone on and biopsied, and we still see capillaritis. So it doesn't necessarily mask it.
All right. We might move on now to our next speaker. Sharon, I think there may be one or two more questions for you in the chat. Maybe you can chat offline or follow up with them. Thanks again for the talk and answering the questions. I will turn it over to